But, you know, the thing is, it's always been
Why is that screen so dark? That middle one. The big one. So we're seeing if we can live stream. There's Dr. Williams over there. We are live here in Damaso. Let me show you. There's Wunha. So we are here in Damaso if you've never been in here before. So, bless you.
Thank you.
Oh, there's the dean. The dean is here. So she is coming up. Say hello to the alumni group. JC's asking if we can do this into the. Well, he's asking Dr. Williams if it's okay. So there's.
You are. How are you?
I'm good. How are you doing?
Good. Yeah, for some reason I got started at 6. Like, I rushed from quitting.
6?
Yeah. Oh, right. Maybe that's where I got confused.
Yeah, because they're just.
I parked here, but then I didn't want to come to the run, so then like
That may be why, because it starts at 6. There
that
you
must
are.
be what I had in mind.
They confuse us for starting things at different times.
Is that okay?
He probably has.
Okay.
So, how was the exam?
Oh,
Really, how was it? I mean,
you know.
I had to take it years ago for chess. So,
You mean
was
on?
it like that, or did you ever?
No, I never took chess. So, but it was you
It
know.
was 150 questions too. And
Oh, was
4
it?
hours long.
Oh,
Yeah.
okay. Oh, yeah.
That was back in the day, though.
You know, it. I only had like 4 questions I had to go back to in each
That's
section.
not bad.
That's what worries me.
Maybe
That's what worries me.
You're going to be the new high scorer.
No, no, oh no, no. No, that's what worries. That's what worries me because it's like, okay, I was, some I knew right off the bat, others, but most of them I had to I got it down to 2 pretty quickly,
Well, that's good.
and then I could just go through and all. But
That means you know
I'm
How
hoping.
did Hildemar feel?
I don't know. It's hard to read him. He said he felt better than the first time, but he still. I think he still did. He say something about he still didn't have enough time. Like
Really?
my second section, I had like 30 minutes left, and so
Oh, well, maybe you do the test taking thing.
yeah,
Comfortable with that.
yeah, and I think it's a language thing too. I mean, it was like a lot of scenario and a lot of distractor kind of things, and that was too bad about Adam. I
Oh, I know.
I couldn't believe that, man. I mean, he was all geared up and
Well,
ready to go.
These things.
Yeah. So well then,
Technology is not always your friend.
I know. Well, October. How's it going?
Fine. Nice to hear.
Do they call this the gathering of the saints?
Well, usually I'm the same.
Oh, Michael is watching.
Yeah. How's it going being on the
So look at who we have behind
committee
here.
for the USDA nutrition?
So we have some. Right behind me is the dean and Dr. Sabte and Dr. Kim, Moonha Kim.
Because they want to finish
So
the last of the meetings
I'll switch it back.
in 3 weeks.
So we're waiting for Dr. Williams. You can see his. Hey, Michael. How's it going there?
When are they done? When are they
There
done?
is the title.
You done?
Well, that's the
Okay.
thing. I'm not done because the staff is the one that gets the papers and extracts the papers. We have to criticize the papers. I mean, and then make the conclusions. Discuss the things. So there is reports that we have, and then besides the face-to-face means that is then when there is more than four.
So it's supposed to start at 6:30.
I'm saying the subcommittees
So
are smaller.
Right.
So, and I remember
hopefully it'll be starting pretty soon. I don't know what time is it. What time is it?
Well,
anyway, I'm overwhelmed because I mean this quarter.
you won't recommend it.
Oh, it's 6:28.
I thought it was more. I knew it was more, but not as much.
You didn't know it was this much.
There he is.
And also the issue
He's right there.
is the work and also a little bit of stress.
Yeah.
Either because they have selected purposely this way. They don't even want to touch the issue of sustainability.
Even though the rest of the world.
The world does. And I'm telling them, I mean, I understand what I'm saying. At least in the introduction,
Yeah,
we have to address. Otherwise, I mean, the steps will be behind it.
Right.
The issue of vegetarian diets, they don't like it. So there is but among the members, I mean, I understand about the USDA, and I said, we were supposed to be independent. So we have to say what we think is right. Whether it's political or not, the USDA is going to think business.
Do you think that this time where everybody else sees it too late, they would at least be
I think they put me as a figure. They have selected say, well, at least we have one that defends this.
Dr. Hart is there. Okay. Looks like Dr. Hart's gonna read the intro.
Not showing too much bias.
as they say, it builds character.
What will kill you and make you stronger? Well, that's part of the experience, though.
Yes, I saw you earlier. But good to see you again.
Okay, at 6:30, we'd like to get started. Thank you all for being here. We got a few more coming in. Anybody who has 5 lines after their name, you know they must be important. Particularly when the last one says Harvard, why, you know that's important. But I'd like to suggest that our speaker this evening has 2 things even more important than that. He's on our board and has been for a number of years. So thank you, Dave, for serving us on the board of Loma Linda Univ Health. And perhaps even more important than that, he's one of our alumni. So
Yay.
Dave graduated from the School of Public Health. What year?
1981.
1981. So we're very proud to claim him as one of our alumni.
Yay. The dean's very happy about that.
So I just want to welcome you all. Someone else is going to do the more formal introduction, and give a bit of background. But thank you all for being here for what I consider an important thing. Let me mention one other thing as well, though. Tomorrow night, same place, at 6 o'clock, not 6:30, but 6 o'clock, is also a seminar on coronavirus, dispelling myths.
Don't be late.
So you all are welcome to that as well.
Yeah.
Well, good evening, and thank you all for coming out on a weekday night. My name is Jagger Ackerman. I'm a 4th-year medical student here and president of our class's AOA chapter. It's my privilege to welcome you to our first ever Loma Talk, sponsored by the School of Medicine, AOA Medical Honor Society, and the Institute for Community Partnerships. It's our goal and our vision that this would be the first of many TED Talk style talks in the future, aka Med Talks, and that would happen on a at least semi-annual basis. Tonight, it's our unique privilege to have a speaker coming in and talking about a topic on social determinants of health, and this would not be possible without the help of Dr. Billiard in the School of Public Health. I'd like to thank him for all of his contributions and invite him to welcome our speaker, Dr. David Williams.
So this whole idea started with a lecture of social determinants for 4th years, and it wasn't even me who did the lecture, it was one of my associates. but she came back and said the student in his 4th year has this idea about doing TED Med Talks, and he's going to be in touch with me. So Jordan Thompson, right, reached out and said, yeah, we want to start these Med TED Talks, but we want like a big name speaker. And I said, well, we always have a big name speaker here at least 3 to 4 times a year. And I feel like sometimes we don't take full advantage of that. So I know Dr. Dave Williams from APHA. He's a regular at the American Public Health Association. Who are my public health students? My class up here? Okay, thank you. Am I taking attendance tonight? So at APHA, you can always tell where Dr. Williams is speaking because there's always a line out the door. And a couple of years ago in San Diego, he was a keynote speaker for an audience of, I don't know, about 12,000 people. I mean, it was a packed hall. And I didn't get there late, but the doors were shut when I got there because they said the fire marshals weren't allowing any more people in. So I had to sneak in, but I took somebody else's place. So somebody that was leaving, I took their spot. So I don't think I broke any rules. But that place was packed, and it was a very proud moment to see one of our own from Loma Linda up on stage and doing his thing. I do want to mention kind of the trajectory of education of Dr. Williams. He went to academy at St. Lucia SDA Academy, where he's from. Studied at Caribbean Union College, then did his MDiv at Andrews University, his MPH here at Loma Linda University School of Public Health, his PhD in sociology at University of Michigan, and then has been a professor at Yale, at University of Michigan, with Dr. Susanna Montgomery. I think they were contemporaries.
Classmates.
At that time. Classmates at that time. So they're from the same class. And now he is currently the Norman Professor of Public Health. This is the shortened version, as you can see up there. The Norman Professor of Public Health and Chair of the Department of Social and Behavioral Sciences at the Harvard School of Public Health. He's also a professor of African and African American Studies and Sociology at Harvard University. Last year was a big year for Dr. Williams. He was, actually 2 years ago, he was named a member of the Kellogg Foundation Solidarity Council on Racial Equity, along with people like Brian Stevenson. If you haven't read Just Mercy or seen the movie, I encourage you to do so. On that council is also John Legend. I think some of the younger folks will know who that is. And for those of you who listen to Latino USA, also Maria Hinojosa is on that council. That was in 2018. In 2019, Dr. Williams was awarded the Harvard Faculty Humanitarian Award, along with Brian Stevenson. There's a connection between the two awards that they received. In 2019, he was elected to the National Academy of Sciences, and this year, I think in January, he was elected Academic Goodwill Ambassador for St. Lucia. So I can go on, but we're really here to listen to him speak, and you can read about him online if you want. Let's give Dr. Williams a warm welcome.
Well, good evening, everyone. It's good to be back at Loma Linda, always is. I had a full year here, and it was a good year. And Loma Linda has certainly shaped my training in public health and my approach. Very thankful to the teachers I had, especially to my advisor, Dr. Joyce Hop. So I'm thrilled that her daughter is now the dean of the school. It's my inspiration. What I want to do tonight is to quickly, I have a lot of territory to cover. I'm going to run through it quickly. I have more slides than I should have. But I have to do this because I will say things that people won't believe me if I don't share the data. So even if you see it for a few seconds, at least you saw it. What I want to do is two things. First, I want to talk about social inequalities in health and give you some examples of the social inequities that exist. And then I want to review the evidence of what we can do, the scientific evidence we have of the kinds of interventions we can make in order to make a difference. So globally, there are large inequities in health by socioeconomic status. I'm a sociologist. When we say socioeconomic status, we're talking about income, education, occupational status, wealth, any marker of social status. And in virtually every country of the world where we have data, persons of higher socioeconomic status have better health than persons of lower socioeconomic status. I'm showing you one example. This is national data for the United States, looking at overall mortality, and these are relative risks by income. This data would be similar if I showed it by education. And what you can see, compared to persons with household incomes of $115,000, that's about twice the median income in the United States. Persons who are low income, less than $25,000, have an overall death rate 3 times higher than those who are high income. And you could see it's not a gradient effect, it's not a threshold effect, it's a gradient effect, so that at every higher level of income, the death rates are lower. And that pattern is true virtually everywhere in the world where we have data for virtually every health outcome. There are few exceptions, but in general, this is a pronounced pattern that we find. Because socioeconomic status is such a powerful driver of inequities in health, you would expect then to find inequities in health by race and ethnicity, because race ethnicity captures some variation in socioeconomic status. And I'll give you one example, a data point. This is data from the US Census Bureau, household income in the United States for the year 2015. Instead of putting the numbers up, I have presented the data in a way in which you can't possibly miss the point. So I'm standardizing on the household income of white households as $1. And for every dollar of household income white households in the US nationally receive, Asian households receive $1.23. That needs to be contextualized by 2 important points. 70% of Asian households in the United States are immigrants. They come to the United States with high levels of education. And that's number 1. Number 2, Asian households have more persons contributing to household income than any other category. So if I, even with these data, use a per person or per capita measure of income, whites would have the highest levels of income. Okay, but compared to 3 of the traditionally disadvantaged groups, for every dollar of household income white households receive in 2015, Hispanic households receive 72 cents, American Indian Alaska Native households 62 cents, and black households 59 cents. What is stunning about a 59 cents number is that it's identical to the racial gap in income in 1978. I didn't misspeak, you heard me correctly. 1978 was the peak year of the narrowing of the black-white gap in income as a result of the anti-poverty policies and the civil rights policies of the 60s and 70s. And in 2015, we're exactly where we were in 1978. Has that level been stable over this entire time? No, it got worse throughout the decade of the 80s. It was not until 1994 that blacks got back up to the 59 cents figure, and it's been a penny up and down before that. The important point is, this racial inequity is much larger than most of my students think it is. And more importantly, looking at data on income dramatically understates the degree of economic inequality. Why? Because income captures the flow of resources into the household. It tells us nothing about the economic reserves that households have to cushion shortfalls of income. You get that from measures of wealth, measures of assets, and here is national data for the United States. For every dollar of wealth that white households have, Latino households have 7 pennies and black households have 6 pennies. So there's even marked economic inequality in the United States. So not surprisingly, there are racial differences in health, given the racial differences in economic status. Here's national data for the United States. Infant mortality, that's a chance of a baby dying before its first birthday. And you could see that both African Americans, and I use the term African Americans and black interchangeably, American Indians or Native Americans interchangeably, have elevated risk of babies dying before their first birthday. Both the Latino population and Asian population show an intriguing pattern. And it's this. These are groups heavily made up of immigrants. what we find in national data for the United States is immigrants of all racial ethnic groups have better health than their native-born counterparts. Lower infant mortality, lower overall mortality. That's the good news. The bad news is the longer immigrants stay in the United States, the worse their health becomes. So that if the data for Hispanics particularly were broken out by nativity status, you would see a different pattern. Okay, the point I want to make though is the racial differences we see in the United States is found around the world. And I just will show you quickly a few examples to illustrate the point. Here's infant mortality data for England and Wales. Here's the white British, other white immigrants to the UK, mainly from Eastern Europe. Blacks from Africa, blacks from the Caribbean, Pakistanis, elevated risk. If we go to South Africa, mirroring the apartheid of South African society, whites have the lowest rates, then comes Indians, then comes colors, then comes blacks. If we go to Latin America, here's the African-descended population in Costa Rica, Panama, Uruguay, Venezuela, Brazil, Ecuador, Colombia. African-descended populations have higher infant mortality than the white population or the majority population in those societies. Here is data from Latin America now looking at the indigenous population. In Costa Rica, Uruguay, Mexico, Colombia, Brazil, Venezuela, Peru, Ecuador, Panama, Guatemala, Bolivia, the indigenous population has high rates of infant mortality. So I have data on New Zealand, on Australia, but you got the point. It's a global phenomenon that stigmatized racial ethnic populations do worse in terms of health. When my career started, most researchers in this area thought that the racial ethnic differences in health were simply a function of racial ethnic differences in socioeconomic status and income and education. And that if you looked at persons at the same level of income and education, race would no longer matter. We now know that life is more complicated than that. And to illustrate that, I'll give you an example of some work we published in the American Journal of Public Health in 2010, using national data for the United States, doing these special analyses, looking at life expectancy at age 25. So at age 25, how long will the average white person live compared to the average black person? There's a 5-year gap in life expectancy. But remember, I spoke to you about the power of socioeconomic status. So if we look at age 25 by education, whites with a college degree live 6.4 years longer than whites who have not finished high school. That is, the gap within the white population by education, is also true by income, is bigger than the black-white gap. And if you look within African Americans with a college degree live 5.3 years longer than African Americans who have not finished high school. So again, within each race, socioeconomic status is a bigger predictor than the racial difference. It's an intriguing sociology of knowledge question, why as a society, if you look at routine reports from the United States government, National Center for Health Statistics, CDC, they only report data by race, seldom by socioeconomic status, whereas the socioeconomic status gaps are even larger than the racial ethnic ones. I'm not arguing for socioeconomic status instead of race, I'm arguing for both. Because this is what you find when you look at both. Even though the socioeconomic gaps are larger than the racial gaps, race matters at every level of socioeconomic status. So among high school dropouts, white high school dropouts live 3.1 years longer than black high school dropouts, and that gap widens as education increases. It's 4.2 years among the college educated. And one of the most striking statistics I will show you tonight, remember, this is national data for the United States. The best off African Americans, those with a college degree or more education, have lower life expectancy than whites with a college degree, lower life expectancy than whites with some college, lower life expectancy than whites who have not finished high school. Or whites who have finished high school, sorry, like whites who are high school graduates. So what do these data tell us? It says there's something profound about socioeconomic status that drives health regardless of your race. But it also says there's something else about race that matters even after you've taken income and education into account. And so over the last 25 years, researchers have been asking the question, could racism be an added factor that is the critical missing piece of the picture that contributes to these racial ethnic differences in health? I could talk a lot about racism, but I'm going to have a short mention of it tonight. One of the key things I want you to distinguish is between what we call individual versus institutional or structural racism. And I want to give you an example of both of them, illustrating them by weighting. So researchers at Portland State University asked a question. In the great city of Portland, when a black person stands at a crosswalk demonstrating an intention to cross the street, and a white person stands at a crosswalk demonstrating an intention to cross the street, does your race determine how long you wait to cross the street? So they took 3 black males and 3 white males, dressed them similarly, put them at different intersections at different times of the day, and monitored to see what happened. And they found that multiple cars were twice as likely to pass a black person intending to cross the street, and that blacks had to wait 32% longer to cross the street. That's individual discrimination. We're talking about what individual drivers do faced with the stimulus of someone waiting to cross the street. I want to give you an example of institutional discrimination. We're in election time, so it's a good time to think about that. This is national data for the United States. How long did persons wait in the 2012 presidential election have to stand in line at a precinct to wait to vote? This is national data for the United States. You can see on average African Americans waited 23 minutes, whites waited 12 minutes, and you can see the variations in between. None of that reflected individual discrimination. That did not reflect the behavior of local precinct workers. The outcome is different. How long you had to wait mattered, and it varies by race on average. But in fact, it reflected a number of what we call institutional processes. It reflected powerfully where you voted and what was the budget allocation, what were the space allocations, what was the level of staffing. So it's a number of policies that had nothing to do with the behavior of local precinct workers, but nonetheless systematically produced unequal outcomes. And the most powerful ways in which racism operates in our society is not through individual beliefs and behavior, even though there are atrocious ones that we see from time to time, but it's through institutional mechanisms and processes that produce unequal outcomes. In my TED Talk, I talked about a mechanism of institutional racism that I call the secret source that drives racial inequality in the United States. It's institutional, so we don't see it, but it's powerful in the forces that it produces. So the mechanism of institutional racism, and I'll show you, highlight for you some of the key scientific studies that show its overwhelming impact, is residential segregation by race. A policy that was developed in the late 19th century after the slaves were freed. There was a desire to maintain the races living in separate areas. John Sell was a historian at Duke University. He wrote a book about the origins of segregation in the US South and apartheid in South Africa. He showed that the framers of apartheid in the early 20th century got the idea of apartheid from the United States, from looking at segregation in the United States. They looked across the Atlantic, they saw it and how brilliantly it was working, and they said we can implement it in our society. But importantly, Sell argues that residential segregation by race was one of the single most successful domestic policies of the 20th century. It's beneath the radar screen, but it's producing dramatic impacts. And you're saying, what does that have to do with health? Well, for most Americans, where you live determines where you go to school and the quality of education. So it determines your trajectory of socioeconomic status. Where you live, research shows, determines your access to job opportunities, determines the quality of housing, the quality of neighborhood environments, determines whether it's easy or not to exercise in your neighborhood, whether you have access to fresh fruits and vegetables, whether you're exposed to nearby nature, the level of physical, chemical, toxic exposure. Research shows even the access to quality city services, but also to good medical care varies by place. So place is a powerful predictor. In the city of Chicago, for example, if you look at the difference between the census tract with the highest life expectancy and the one with the lowest life expectancy, it's 30 years. In the city of New Orleans, there's a 25-year difference. 2 miles, 2 neighborhoods, 2 miles away, 25-year difference in life expectancy. Place matters profoundly in public health. It is widely said today that your zip code is a better predictor of how long and how well you will live than your genetic code, because of the power of place. How powerful is place? These are William Julius Wilson and Robert Sampson, two of America's most eminent sociologists, both at Harvard, did a study of the 171 largest cities and said there's not even one city where whites live in equal conditions to those of blacks, and that the worst urban context in which whites reside is considerably better than the average context of black communities. The power of segregation producing inequality. Another Harvard economist, another Harvard professor and economist, this is David Cutler, until recently the dean of the social sciences at Harvard. He did a national study looking at blacks and whites making it in the labor force and showed with fancy, rigorous econometric models that if you could statistically eliminate residential segregation in the United States, you would completely erase black-white differences in income, in education, and unemployment, and reduce black-white differences in single motherhoods by 2/3. All of those differences are linked to inequalities linked to place. More recently, Dolores Acevedo Garcia was a colleague of mine at Harvard, now at Brandeis, has released just last month the Neighborhood Opportunity Index. You can get it on diversitydata.kids. For every county in the United States, they have calculated the opportunities for children, looking at the quality of institutions, looking at high school graduation rates, access to persons with skilled jobs, the economic resources at the community level, the physical, chemical, toxic exposures at a community level, and finally the resources that exist for kids. So it's a national data set with these written neighborhoods in terms of the opportunity for kids. And this is what she finds, that 67% of all black children in the 100 largest metropolitan areas, and 58% of all Latino kids, and 53% of all Native American kids are living in very low or low opportunity neighborhoods, compared to 65% of white kids and 62% of Asian kids are living in high or very high opportunity neighborhoods. So a lot of the inequalities that exist are driven by inequalities at a level of place that reflect the powerful legacy of residential segregation. It's beneath the radar screen. No one is talking about it, but it's a driver of unequal outcomes in health, in education, and so forth in the United States. Another Harvard faculty, Raj Chetty, economist. You can go to you can Google Opportunity Atlas. You can put in your neighborhood, and you can look at the degree of inequality within your neighborhood. What he has done, something that had never been done before, he looks at the intergenerational transmission of inequality by studying all of the census tracts in the United States. And in his analyses, he looks at blacks and whites at the same level of income and looks to see what are the outcomes for their children. And what he finds, that black boys have lower earnings than white boys, parents who had the same income, in 99% of all census tracts in the U.S. However, he finds if black boys do live in neighborhoods with good resources and good race-specific factors, they do just as well. The problem is there's only 1% of census tracts in America that have that reality. So the power of place in driving inequality is really powerful. The take-home message here is that therefore these inequalities that we see aren't random effects. They didn't just happen. They reflect the successful implementation of social policies. Social policies doing exactly what they were intended to do. So I've talked about one mechanism of racism. I'll talk quickly about the second one, and then we're going to talk about what are the solutions. Martin Luther King in 1967 said this: discrimination is a hellhound that gnaws at Negroes in every waking moment of their lives, declaring that alive their inferiority is accepted as a truth in the society dominating them. Now, Martin Luther King was not a social scientist, but this is a hypothesis that could be tested. If it's true that it's a hellhound that gnaws at people in their waking moments, at least it could have negative effects on mental health. And so we have also been looking at the ways in which exposure to discrimination, one mechanism of racism, has negative effects. This is what I'm most famous for globally, is the Everyday Discrimination Scale, a scale I developed having read qualitative literature on descriptions of discrimination. It's very widely used around the world, and it captures not big things. I have a measure that captures big things, but these are just little things. You're treated with less courtesy and respect. People act as if they think you are not smart. You receive poorer service in restaurants or stores. Little indignities on a day-to-day basis. Just to illustrate what we have found with not just the scale, but similar measures of discrimination, it's linked to increased risk of breast cancer. Allostatic load is a summary measure of biological dysregulation, visceral fat, C-reactive protein, coronary artery calcification. There's a number of studies that show persons who consistently score high, even on the Everyday Discrimination Scale, followed prospectively. Everyday discrimination, those little experiences, are an independent predictor of premature death. Elevated mortality risk linked to everyday discrimination, just a broad range of outcomes, telomere length. You name the outcome, it's powerful. I have been surprised at how powerful the relationships are between the stress of discrimination and health outcomes. We now today have studies from Australia, New Zealand, South Africa, the United Kingdom, and the United States that find when you look at racial ethnic differences in health and you adjust for income and education, and there's still a residual effect, that effect is further reduced when you add a measure of interpersonal discrimination to the model. So we now know that one of the reasons for racial differences in health is higher levels of exposure to interpersonal discrimination. By the way, although I developed the measures of discrimination to capture racial ethnic differences in health, minorities are not the only individuals who experience discrimination. Whites experience discrimination as well, and the effects are the same. The levels of discrimination reported by whites are lower, but the effects on health are the same, irrespective of your race, if you have been treated unfairly or badly by others. It's a powerful message to all of us about how we treat each other on a day-to-day basis can be a driver of their health in negative or positive ways. Okay, I've given you a high-level but very quick overview of racial and socioeconomic inequities in health. What can we do about them? Strategy number one, we need to build more health into the delivery of medical care. There's many things we need to do along those lines. One of them is to ensure access to care for all. And just by improving access to care, we can actually eliminate not all, but some inequities in health. And I'll give you a powerful example. It came from the state of Delaware. The state of Delaware decided that they would provide colorectal cancer screening available to everyone who lived in the state. And 2 years later, they added colorectal cancer treatment would be available to everyone who lived in the state. What has been the impact? They started this in 2001, and by 2009, here you can see the black-white differences in screening rates. By 2009, they were eliminated, and they were eliminated in the right way. I mean, one way to eliminate it is to lower the rates for whites, right? So they eliminated them with a dramatic improvement in the rates for African Americans and for whites. Both groups improved as a result of this program. What they also found was here were the incidence rates, new cases of colorectal cancer. And you can see again a reduction for both groups with larger reductions for blacks than for whites, so that they equalize the incidence rates. And most strikingly of all, virtually eliminated, almost completely eliminated, the colorectal cancer mortality rates. And the research showed that this actually saved the state money by providing free screening and treatment for the population. Because colorectal cancer was caught earlier, it actually saved the state money. So it's an example for one outcome. This is not necessarily true for every outcome, but it's an example for one outcome that by ensuring high quality access to care for all, we can actually eliminate some of the inequities in health that in fact exist. What else do we need to do? Build in more health into the delivery of care. We need to eliminate inequities in the receipt of high quality care. This is influential National Academy of Medicine, now was called Institute of Medicine back in those days, report that was released in 2003. The history of this report was the United States Congress asked the Institute of Medicine to conduct a study to identify what happens to individuals in these great United States when they enter medical care context. Does your race determine the quality of care you receive? It was not about access. Given access, this quality varied by race. I'll tell you what I served on the National Academy of Medicine panel back then. These panels don't do original research. What we do is we review the available evidence. We have found about 180 papers at that time, published peer-reviewed papers that had addressed the question, and 80% of them have found that across virtually every therapeutic intervention, from the most simple to the most complicated, blacks and other minorities receive poorer quality care and less intensive care than whites. I'll give you one example. Dr. Todd was an emergency room physician at UCLA. He asked a simple question. When a patient shows up in the emergency department at UCLA Medical Center with a long bone fracture, broken bone in the arm or legs, does your ethnicity determine whether or not you get pain medication? And he found that 55% of all Latinos treated with a long bone fracture at UCLA in the prior year did not get pain medication, compared to 26% of whites. Dr. Todd was a good researcher. He said it's confounded, it's something else. So he statistically adjusted for the age of the patient, whether they got injured on the job or not, whether they spoke English or Spanish, what time they showed up at the ER, how long they spent in the ER, and statistically, after he adjusted for all the potential confounding factors, the single biggest predictor of whether a Latino got pain medication was whether they were Latino or not. That was the biggest predictor. In fact, statistically adjusting for everything, Latinos were 7.5 times less likely to get pain medication. Dr. Todd moved from UCLA to Emory University in Atlanta, repeated the same study at 3 large emergency rooms in Atlanta, looking at blacks and whites, and found exactly the same thing. A black patient with a broken bone in the arm or legs goes into the emergency room, is less likely to get pain medication. Now, folks, do not focus on pain medication. Because this was documented in every area of medicine. There were 80 studies in the treatment of cardiovascular disease. And since 2002, there are multiple studies that document this pattern still persists in the United States. So how on earth do we make sense of this paradox? In a country with arguably the best trained medical workforce, where most healthcare providers wake up every morning intending to do the best for each and every one of their patients, nonetheless produce a pattern of care that appears to be so discriminatory. The explanation that was offered by the Institute of Medicine back in 2002 was most likely this was implicit bias. We had at that time no direct studies linking bias on the part of the clinician to differences in quality. Today we have multiple studies linking bias on the part of the clinician to poorer quality care for patients. And it's not about race, fundamentally. Implicit bias is about how all human beings process information. We process all of the complex cognitive information we face every day by putting things into categories. Social categorization, it's normal. That's how we all function. The question is, what's the society in which you were raised? And what categories have negative attributes associated with them that you were socialized with from early childhood? And so without thinking, you make the connection. What research finds? In 1/3 of the time it takes to blink your eye, when you meet someone, you notice their age, their gender, and their race. And if you have negative associations linked to those social categories based on your socialization, you will treat that person differently. That is, you will discriminate against them without your conscious awareness and with no intent on your part. I tell my students that I think of myself as a prejudiced person. Why? Because I think of myself as a normal human being. And if you're a normal human being, you're probably prejudiced. Remember, this is not about race. This is just about social categories. Every society, every culture has in-groups and out-groups. Groups that are viewed positively and groups that are viewed negatively. You may not be racially prejudiced, but what are the deeply embedded stereotypes you have about fat people, about gay people, about poor people, about women? These are these are normal processes that occur based on embedded beliefs we have in our minds based on our socialization. The good news is, there's a study out of the UK that shows 1 dose of a beta blocker can eliminate implicit bias for the next hour. No, really, high quality, double-blind, parallel controlled, randomized controlled trial. 1 dose of a beta blocker eliminates implicit bias. This is really important because we live in a world where some people say that implicit bias is just made up, it's not real. If we can eliminate it with a pharmacologic agent in the brain, it shows this is a real phenomenon that can be intervened on. Now, I don't think it's practical to medicate the entire workforce for the rest of our lives. So the good news is there are a number of social psychological strategies that have been documented to be effective in reducing implicit bias, like stereotype replacement. If you think of all women as weak, why not practice some nights just before you fall asleep, imagining what a strong woman looks like? That's what's called stereotype replacement. Individuation, we normally process information when we meet someone by putting them into social categories. Individuation says, I will focus on this person as an individual and not on the social categories they belong to. Perspective taken, imagine what the life of that older African-American male you're treating was like. What if I had to live in his shoes? How would I think and how would I relate? So there are a number, increasing interracial contact, there are a number of strategies. And I'd like to talk about the Divine solution. Professor Patricia Devine from the University of Wisconsin-Madison has shown you can put all of these strategies into a single program and increase awareness level of bias and concerns about bias. People can, in fact, implement these multiple strategies, and they are effective in reducing implicit and explicit bias. So there's actually evidence out there of what can be done to address it. This is a point Jonathan Kahn from Boston University has just written this book, where he thinks that some people just use implicit bias as a way to look only at the individual level and not sufficiently paying attention to issues of power and group interests and structural racism. So implicit bias is not a panacea for everything. We need to think of the ways in which implicit biases have shaped the normal functioning of institutions. That's what they're calling about structural competence, the ways in which the normal function of institutions have been shaped by implicit bias. Okay, what else do we need to do? We're talking about building more health into the delivery of medical care. Provide care that addresses the social context. This is from the World Health Organization. They ask, what do we accomplish if all we do is treat illness and send people back to live in the same conditions that made them sick in the first place? So what can we do? This is a new report from the National Academy of Medicine, released just last year, integrating social care into the delivery of medical care, of health care. And it talks about the different ways in which we can do this. One is through increasing awareness activities, that is activities that identify social risks and assets, through adjustment activities that focus on altering the clinical care to accommodate the barriers that individuals face, assistance activities that provide assistance in connecting patients with relevant social care resources, alignment activities that facilitate synergies and invest in and deploy social care assets in the community, and finally, advocacy, activities that work with other social care organizations. The point that they're showing you there are multiple ways in which the system can, in fact, have an impact. And I'm going to illustrate that just by thinking of one problem that some patients might face is transportation. So in terms of transportation, awareness means you will ask patients about their access to transportation, assess their transportation needs. In terms of adjustment, you can say you can reduce the need for in-person healthcare appointments by using other options such as telehealth appointments. In terms of assistance, you can provide transportation vouchers so that patients can travel to their health appointments. In terms of alignment, you can work with other entities in the community to invest in community ride sharing. In terms of advocacy, you can work with the political leadership to promote policies that fundamentally change and alter the transportation problems in the community. So again, there are multiple paths by which healthcare providers, healthcare systems can play a role. One other thing we need to do in terms of building more health into the delivery of medical care is to diversify the workforce to meet the needs of all patients. What research shows, especially as we are facing a much more diverse future than we currently have, but research on the medical workforce shows that persons who come from underrepresented minority backgrounds are much more likely to practice in underserved areas and are also much more likely to practice in primary care specialties. Two of the big needs of our health system as a whole can be accomplished by ensuring a greater challenge, a greater number of persons from underrepresented backgrounds. This just illustrates the challenge. Percent medical school graduates in 2015, this is from the American Association of Medical Colleges, 5% African American, 0.1% Native American, 4.6% Latino, 0.3% of 1% Native Hawaiian or other Pacific Islander. So there's a lot of room for improvement that can be done in terms of increasing the number. Here was another report from the American Association of Medical Colleges. In 2014, there were 27 fewer African American males in medical school than in 1978. Progress that has been made is much smaller than most people think. In the mid-1960s, 2.9% of all practicing physicians in the US were black. In 2012, 3.8% of all practicing physicians were black. So there's a lot of room for improvement and increasing diversity that can, in fact, make a difference. One of the intriguing things, and I have the data, but I'm not going to show it in the interest of time, when most Americans think of affirmative action policies, they think of programs that have helped underrepresented minorities. In fact, the programs were directed at women and underrepresented minorities. The programs have worked much better for women than for underrepresented minorities. We don't think that way, but that's the reality. And what it illustrates, why have affirmative action programs work better for women? Most of those women were white. Why did it work better? Because those women were prepared to take advantage of the opportunity. And it's not enough to just open the door of the opportunity if we are not investing in the pipeline programs, if we're not improving quality of education at a local level so that those persons are prepared to take advantage of the opportunity. So one of the really important things we need to do is what we do to, in fact, enable individuals to be able to walk through the gates. Plato paraphrased said, there's nothing so unfair as the equal treatment of unequal people. So if we look at people who are very unequal, and we treat them all the same, there is nothing so unfair as that. It's just, we talk about strategy number 1, building more health into medical care. Strategy number 2, creating communities of opportunity to minimize, neutralize, and dismantle the systems of racism that create inequities in health. Quickly, I'm going to run through several things. All of them, there's lots of good evidence. I'll give you a reference at the end, and you can go and read more about it. One is creating communities of opportunity, invest in early childhood. The Abecedarian Project in Chapel Hill, North Carolina is one example of early childhood development project. In the Abecedarian Project, babies at birth are randomized to be placed into a safe, nurturing environment with good nutrition, good pediatric care, good intellectual stimulation, birth through 5. And then after that, they're on their own. They have now been followed over time. By the mid-30s, an intervention birth through 5 by the mid-30s, markedly lower levels of multiple indicators of cardiometabolic risk. I'll give you one example. Here's the systolic blood pressure in the control group versus the treatment group in the mid-30s. Large differences in BMI. All that was done is birth through 5, providing a good, healthy, stimulating environment. These are all poor kids, 80% of them African American, dramatic health benefits. The Periphery school study is another famous early childhood intervention done in Ypsilanti, Michigan. Again, kids preschool age were randomized to receive for 2 years an intervention, a preschool, where their skills were improved. 40 years later, they've been followed, the two groups, the intervention group and control group. 40 years later, those who got the preschool intervention compared to their controls, lived in the same public housing project. 40 years later, the intervention group had higher levels of income, higher levels of education, higher levels of marriage, higher levels of savings, less involvement with the criminal justice system over their lifetime, less involvement with the social service system over the lifetime, and for every dollar invested, a $17 return to society.
Whoa.
Okay, so we know that these are both randomized controlled trials I've told you about. So we have the highest quality scientific evidence of the kinds of interventions that have long-term positive impact and that save society money. What else do we need to do to create communities of opportunity? Reduce childhood poverty. This is a UNICEF report, and you could see that the US ranks 34th in the world in childhood poverty. There are lots of countries doing a much better job than we are. And childhood poverty varies by race. This is national data for 2016. 1/3 about blacks and Native American kids growing up in poverty, about 25% of Latino kids, and about 11% of white and Asian kids. In terms of numeric number, the largest number of poor kids, the largest number are Latino kids, the second largest number are white kids, and then comes black kids, just numerically. We're just adding up the numbers. This is a really important chart. Don't miss the point. This is from the UNICEF report. They are showing the level of child poverty rate in different countries produced by the economic system. So let's look at Ireland. The economic system in Ireland produces a child poverty rate of 42%. After taxes and transfers, it's reduced by 8%. Taxes and transfers refers to the policy preferences of the society. So after the society implements its policy preferences, it's reduced from 42% to 8%. And you can look at other countries. Hungary, 31% to 10%. Australia, 38% to 12%. Canada, 25 to 13%. The US, 24 to 23. So the point is, the problems we have reflect choices we are making as a society and not options that are inevitable. What else do we need to do? Communities of opportunity need to keep the social safety net in place as a resilience resource. What do I talk about the social safety net? The programs that in fact support it. Let me give you an example. Let's go down a walk down memory lane. In 1981, there was the first year of the Reagan administration, there was a 1981 Omnibus Reconciliation Act. What did that program do? It led to 500,000 people losing welfare, 1 million people were dropped from food stamps, 600,000 lost Medicaid. In some states, less than 20% of the poor were covered with Medicaid. What was the impact of this? There was an increase nationally in low birth weight. There was a decline in infant mortality that slowed. Over 250 community health centers closed in the United States. 1 million children were dropped from school meals. There was an increase in infant mortality in poor areas of 20 states. There was an increase in women not receiving prenatal care. There was a 143% increase in anemia in pregnant women. There were new cases of measles, and the increase in measles for the first time since 1963. All of this happened within 2 years of the social safety net being savaged. There are proposals in Washington, D.C. right now, proposed president's budget that would savage the social safety net. That will only worsen health for vulnerable populations in the United States. What else can we do in terms of communities of opportunity? Enhance income and employment opportunity for youth and adults. There is a lot of empirical evidence, and I don't have time to review them in detail, but that shows if you give poor people money with no intervention in health, it leads to improved health. We have high quality studies from randomized controlled trials that shows, like the conditional cash transfer programs internationally shows this to be true. I should come back to that. Giving poor women money with no intervention leads to improved health. No, it's really true. Leads to improved health. There's a lot of evidence. I'll give you one example, just one study, but there's a lot of evidence on this. This is a study, quasi-experimental difference in difference design research, very rigorous scientific method, that looked at what's the impact of $1 increase in the minimum wage by using the leverage of some states that have a higher minimum wage. And what they show that $1 increase in the minimum wage above the federal minimum is associated with a 1 to 2% decrease in low birth weight and a 4% decrease in postnatal mortality. If all states in 2014 had increased their minimum wage by $1, there have been 2,790 fewer low birth weight births and 518 fewer postnatal deaths per year. So just additional income can make a difference. What else do we need to do? Certainly improve neighborhood and housing conditions. If segregation is such a driver, then improving that. Can this be done? I want to give you a dramatic example. Purpose-built communities. And I'll give you the first purpose-built site was in East Lake, Atlanta. And I wanted you to see the transformation that took place in East Lake, Atlanta. It was East Lake Meadows was an African-American public housing project. 90% of families who lived there were victim of a felony every year. The housing was dilapidated. Only 13% of adults were gainfully employed. It was one of the worst performing schools in the state of Georgia. 2 years ago, I visited the villages of East Lake. That public housing project was torn down with the community leadership working with a wealthy philanthropist and the Atlanta Public Housing Department. And the villages of East Lake, there's been a 73% reduction in crime, 90% reduction in violent crime, high quality privately managed housing, half of them public housing, half of them at market rate. All able-bodied persons are employed, and the school, although 60% of the students still qualify for reduced price lunches, so they're still low income, 60% is one of the best performing in the state of Georgia every year. It shows it can be done. We, by the way, purpose-built communities, you can Google it, purpose-built communities, it is providing free technical assistance to any community in the United States who wants to replicate the model. I was the keynote speaker for a conference for Purpose Built 2 years ago, and there were more than 800 people in the audience, people from all over the country trying to replicate, to learn, get the technical assistance to replicate a purposeful model. My final point, and then I'm going to stop. Strategy number 3, we need to raise awareness levels of social inequities in health and build political will to address them. What's holding us back? I've shown you we have a problem. I've shown you we have science that shows us what to do. Why aren't we making more progress? What are the barriers we need to address? I would argue there are 3 communication challenges. 1, we need to raise awareness level. Most Americans do not know that the inequities in health that I talked about tonight, by socioeconomic tests and by race ethnicity, even exist. If we don't even know a problem exists, we're not prepared to do anything about it. 2, we need to develop political will. That's the biggest, even when people know and they know what to do, how do we build political will? I'll come back to that. And 3, maybe most importantly, we need to start with number 3, we need to build empathy. So what's the elephant in the room? What's really holding us back? This is a picture of W.E.B. Du Bois, a great African-American social scientist of the late 19th century. He published a book in 1899 called The Philadelphia Negro. In the book called The Philadelphia Negro, he has a chapter on Negro health. As he comes to the end of the chapter on Negro health, Du Bois says these striking words: the most difficult social problem in the matter of Negro health is the peculiar attitude of the nation toward the well-being of the race. And he goes on, there have been few other cases in the history of civilized peoples where human suffering has been viewed with such peculiar indifference. So Du Bois is saying in 1899, the fundamental big challenge is we don't care. He called it the peculiar indifference. Scholars today call it the empathy gap. This is a review paper published in 2018. documenting the empathy gap is found on every continent, and that is, we human beings care more and feel more empathy when we see someone in our own group suffering than someone from another group. And this was not based on self-reports. This was based on showing people images of persons being stuck or tortured in some way and measuring their brain reactions in response to it. We care more, show more empathy when the person is from our own group. This is the sad story. This is a study done that shows with white kids, age 5, 7, and 10. At age 5, they're showing a person being stuck with a needle. Some of the people are black and some are white. At age 5, there is no empathy gap. They see everyone experiencing the same level of pain. By age 7, there's a tendency to see the white person experiencing more pain than the black person. By age 10, it is pronounced. So a stable empathy gap is evident in American children by age 10. What can we do to reduce the empathy gap? If people can focus more on individuation, we talked about that instead of social categorization, focus on the uniqueness of an individual. When we see each other as on the same team, it reduces the empathy gap. And when there's greater interracial socialization in our early experiences of life, it reduces the empathy gap. Why does the empathy gap matter? There's a lot of research, and I'll just give you one data point that shows when you don't care, you don't vote for policies to make a difference. It drives policy preferences in the United States. And let me give you one example. Here is a study that's done, national study done for the United States. Given business and industry special tax breaks for locating in poor and high unemployment areas, would you support this? Half the national sample is asked that question. The other half is asked, would you support given business industry special tax breaks for locating in largely black areas? So one is, would you help the poor or would you help blacks? 70% of whites would help the poor, would support it to help the poor. Only 43% would support it if it's to help blacks. The empathy gap driving policy. Among blacks, there's just a 4 percentage point difference. I want to leave you with good news. So here is a recent study that shows a dramatic, randomized controlled trial again, published in Science, dramatic intervention done in Southern California that reduced prejudice. It wasn't racial prejudice, this was about transgender prejudice, but people think that it has application. It's a randomized controlled trial. They sent canvassers, like political canvassers, to knock on doors, and within a 10-minute script, the canvasser tried to elicit with the person they were talking to, feeling some point in their life where they were treated unfairly, so that they would empathize with the plight of transgender individuals. And what they found, that in the script, the voter did most of the talking. The canvasser's job was to help the person learn to empathize. And what the study found was that the intervention led to substantial reductions in prejudice against transgender individuals. It led to support for a law that would eliminate this discrimination. These changes were evident whether the person being canvassed was Democrat or Republican. These changes were evident whether the person making the pitch was transgender or not. And the effects were still evident 3 months later. Now, the stunning thing about this study is there was a commentary published with it in Science that said that the group that developed this study in Southern California tested 13,000 canvassing conversations before they came up with the right words for this to work. It shows the kind of investment that is necessary for us to bring about empathy. I'm going to end. I'll leave you with 3 quotations. Martin Luther King said, "It may well be that we will have to repent in this generation, not merely for the vitriolic words and the violent actions of the bad people, but for the appalling silence and indifference of the good people." Martin Luther King also said that the arc of the universe is long, but it bends towards justice. Barack Obama noted that the arc of the universe may bend towards justice, but it doesn't bend on its own. God sometimes has no hands but our hands. So we can play a role in bending. And finally, I leave you with the words of Senator Robert Kennedy. Each time a man or woman stands up for an ideal, or acts to improve the lot of others, or strikes out against injustice, he or she sends forth a tiny ripple of hope. And those ripples can build a current that can sweep down the mightiest walls of oppression and resistance. We live in a world where there are many mighty walls of oppression and resistance. But each of us can be a tiny ripple of hope, can let our light shine to make a difference. Thank you very much. I know some people need to leave, but I am willing to stay for those who can stay and answer a few questions.
We have time for questions, so if you can just raise your hand, we'll take questions right now.
I'm in front, I get to start. So you offered a lot of solutions, ideas, you showed a lot of actual studies with outcomes, and you ended on the importance of words.
And here's an added resource that's free, available, it's open access, that summarizes all the examples I gave and more. But yes, thank you.
Now, as a Black woman, when I encounter someone with these prejudices that does not understand whether it's intentional or unintentional, do you have any suggestions or studies as to the best approach to help my fellow human being understand that the biases may not be explicit? Or is there a study? How do I address my doctor? How do I address my colleague when I see things that are happening that I know words and the interventions you mentioned could help?
So that's a really good question. So I talked about like the unequal treatment report that was released in 2003. I was a member of the committee. I spoke to a number of nursing medical care organizations. I'm actually right now on the co-chairing a National Academy of Medicine committee. I'll be out in Irvine next week for a meeting on the future of nursing. And one of the things the committee is focused on, our charge, is how do we include the social determinants of health in nursing for the future? That's the mandate of this National Academy of Medicine's committee. But the point I want to make, I spoke to many health professional groups, and the average healthcare provider would say, I would never do this. So what the unequal treatment report found of these differences, I would never do it. The first thing I think is important to do is to normalize it. Because people think that if I admit that I discriminated against, it's not my values, but you see, implicit bias is not about it is not a reflection of your values, it's a reflection of your socialization. It's a reflection of what's deeply embedded in your subconscious. So the first point I think is important to do is do not treat someone who has treated you badly as if they have deliberately done it. Because they'll be defensive, because in fact I am not saying that there isn't discrimination that is intentional, there is. But we think that the most common discrimination in our society, much of what occurs is implicit, and that person is truly, honestly unaware. So I think it's building a relationship and helping them to understand, but don't begin by judging and condemning, because that closes the mind as opposed to opening it so that they could possibly see themselves. So that was what I would suggest as a strategy. It's a normal human process. That's why I told you I think of myself as a prejudice. I'm normal. I would like to think I'm normal. Okay.
On that side.
Wonderful talk, David. Thank you.
Thank you. My fellow church member back in Michigan.
Yeah, known me since high school.
Dr. Chris Boyle.
The process of bringing about social change is very slow. I think we've seen that. For individuals who deal with this on a daily basis, the social determinants of health indicate that this is a bad thing for everyone, but it doesn't probably affect all people in the same way. What are coping mechanisms that people can use individually while we wait for society to get to a better place so that something better can come about for the people hurt by these behaviors?
So let me say two things. So I think social change sometimes takes a long time, but sometimes can happen quickly. And each of us can make a difference within our sphere of influence. So I would want to emphasize that. And we can work together to make a difference in our communities, in our institutions, and so on. So I wouldn't want to suggest that there's nothing we can do when we just twiddle our thumbs. But your question was, is there evidence of things that can make a difference, things that can reduce the negative effects? Yes. I'll give you one example. A study done in Georgia, and it first shows you how bad the problem of discrimination is. This was Gene Brody, is a researcher at the University of Georgia. He's been following a cohort of African American adolescents in Georgia, in rural Georgia, and he assessed these teenagers' exposure to discrimination at age 16, 17, and 18. Those kids who were consistently high at discrimination at 16, 17, and 18, by age 20, I didn't say age 40, by age 20, they have high levels of stress hormones, cortisol, epinephrine, norepinephrine. They have high levels of BMI. They have high levels of systolic and diastolic blood pressure. Linked to discriminatory experiences, 16, 17, and 18, by age 20, we see systemic biological dysregulation. The good news is, that's the bad news. The good news is, that association was not found among those kids who were embedded in warm social relationships with family, friends, teachers. So high quality social ties reduces the negative effects of stress in general, but also the stress of discrimination in health. Similarly, just in the area of discrimination, there's a wonderful paper published, it's entitled The Balm in Gilead, of talking about discrimination in health. And it shows the high levels of religious involvement and engagement reduces the negative effects of the stress of discrimination in health. One of the first studies I published in the area of religious involvement in health, documented in New Haven, Connecticut. People followed over 2 years, looked at their stress levels. Those who attended religious services frequently, high levels of church attendance, reduced the negative effects of stress exposure on subsequent mental health. So the research has documented for stress in general and for discrimination in particular that religious involvement, dependent on religious resources, and high quality social ties can reduce the negative effects. There are some studies that also are finding some psychological resources can matter too, like higher sense of optimism. One study has found that. I would say in the area of the stress of discrimination, most of the early research focused on documenting that it mattered because there was a lot of skepticism within the scientific world that this could even be measured, far less that it had any consequences. And now there's increasing attention to thinking of the kinds of interventions that would make a difference.
I'm looking to engage the children tonight, Dr. Williams. My daughter wanted to ask, did you memorize your entire talk and how did you prepare for it?
I have not memorized my talk. I use the slides, those are my notes. But I teach a semester-long course on this topic. So the challenge I have is to decide which slides do I show and which slides do I not show. So I'm generally familiar with the material. I teach an undergraduate course called Poverty, Race, and Health. I say to my colleagues, I don't tell my students that there's been I call it a Trump effect with my class. So I've taught this class throughout my career, but since I've been at Harvard since 2006, my enrollment in the class has been consistently between 20 and 35 students, which is good. I get a teaching a fellow at 20, so I always want to get at the 20 threshold. I'm a teaching assistant. I taught it right after the inauguration of the new president, and I got to class, and the place was crowded. I didn't know what was happening in the hallway. And there were 79 students trying to get into a class for 35 students. So I had 79 students right after inauguration. Taught it again. I thought this was a blip, right? I had 105 students.
Whoa.
Taught it again this fall. I had 168 students.
Wow.
I have no explanation. I haven't changed the class. I haven't changed the syllabus. All of a sudden, students are much more interested in issues of inequalities, race, and socioeconomic inequalities. I don't know what it is, but that's right. I say it. Okay. I see Jerry Winslow. I see a hand back there. Yes.
Dr. Williams, thank you so much. I teach a class here at Loma Linda, and when I stumbled upon your TED Talk, I had to show it to the class, and the class loved the presentation. So thank you so much, more than you'll ever know, and hopefully we can talk to you in the future. Coming to your point of diversifying the workforce to meet the needs of all patients. I've been in healthcare now for, I would say, 16 years, and I've had the opportunity of going to the top room in the hospital to the basement, and I've seen where the percentages of employees in terms of the demographics, minorities, where the majorities lie, and I've seen basically from recollection what the percentages are. How do healthcare organizations make a difference or make changes in hiring practices to allow more diversity from the boardroom to positions in terms of in the hospital are not necessarily only on frontline and even in hospitality and EVS?
So let me give you two examples. One example is, this is not given the same context, but it's a good example. Within higher education, it is widely believed that the Michigan Mandate, which was a program implemented at the University of Michigan between 1988 and about 1998, what has been the single most successful diversity inclusion initiative in higher education in the United States. What was the Michigan Mandate? The provost of the University of Michigan had chaired a committee the year before on improving diversity and inclusion at the University of Michigan. The next year, he became the president. And then he put in place a committee to implement the plans that his committee had written. Most observers think there are three keys to the success of his initiative. One, he used the bully pulpit. He talked all the time about the key twin drivers of Michigan are excellence and diversity. Excellence and diversity. So he used the bully pulpit. So it was clear to everyone the leadership was behind this, one. Two, he put in place a committee of persons that could implement his plan. It was the second highest ranking individual at every unit of the university. By unit, I mean every school. So typically, it was the academic dean at each of the schools across the entire university. And that was his implementation committee. So they had him backing them, but they could make things happen in their units. And third, many would argue most importantly, he allocated 1% of the University of Michigan's budget to diversity initiatives, an escrow account that could only be used for diversity initiatives. So there was money available to implement diversity initiatives. Minority undergraduate enrollment more than doubled within less than 5 years. The recruitment of minority faculty dramatically increased. The promotion and tenure of minority faculty increased. Minorities being appointed to administrative positions increased. It's a widely successful initiative. That's the good news. The bad news is his presidency ended. There was a lawsuit against the University of Michigan. The new presidents came on board and they had other priorities. So the minority enrollment at the University of Michigan today is half of what it was at the height of that initiative. It does suggest the importance of sustained initiative. Let me give you one other example. The National Health Service in the United Kingdom is the largest employer of BME, that's the term used in the UK, Black and Ethnic Minority People in all of Europe. They implemented a workforce race equality program about 4 years ago. You can look up my name, there's a British Medical Journal article that describes it. I'm the senior author of the paper. I don't remember exactly, but 4 years ago. It has 9 requirements, and it's that every NHS trust, every hospital in the United Kingdom will have to report annually on these 9 factors. What percentage of your board are from BME backgrounds? What percentage of your staff are from BME backgrounds? What percentage of persons who get what are called, it's discretionary additional training, but that prepares you for leadership positions are persons from BME backgrounds? The percentage of, what's the discrepancy between the percentage of BME and non-BME staff that report they've been discriminated against at work? So it's 9 different dimensions. Importantly, it's easy to do that in that context than in the US context. The National Health Service is a system. There is a technical designation in an NHS that when a trust, a hospital, is designated as being not well led, that enters the budget negotiation for the next year. So this workforce race equality standard, every year each hospital has to report their success on these 9 dimensions, and if a trust is not making progress on reducing the gaps, it can lead to them getting the designation of being not well led, which means it would affect their budget negotiations for the next year. So there's some teeth to it that's possible. So far, they're making progress on the easy parts of it, the numbers of people and on boards and so on. They're not doing as well on the, what I would say, those factors that reflect a change in the culture and how people really relate to each other and create an environment of psychological safety. But there is work, there's resources that are out there that can be done. I would point you to the Macy Foundation is having a special issue of academic medicine that brings together about 10 papers on increasing diversity. I was asked to do one, and I recruited one of my wonderful young residents to work with me and do it. So we have one of the papers in there, but that's coming out in academic medicine, I don't know, in the next several months.
Thank you so much. And the reason why I asked the question is, I was just researching the other day, IBM Watson actually tracks, they rank and rate healthcare organizations based on diversity on multiple factors. So, thank you so much.
Okay, I'll take somebody further back. Okay, you're gonna make me run. And then I think Dr. Winslow is next.
Oh, thank you so much for just your hard work for so many years and your research. I have a question, and I'm not sure if you can answer it. What is the role of things like film and art and the cultural dynamics in changing implicit bias and other kinds of prejudices?
Let me give you an example. There has been a marked reduction documented in studies of prejudice and discrimination against gay people in the United States. Now, there still is prejudice and discrimination against gay people, but there's been a marked reduction. It hasn't happened by chance. It's been studied. They have documented, will and grace was one of the tools that was used to reduce discrimination against gays. That if you can present a likable character that people identify with, it reduces their bias, and that person has whatever that characteristic is that is bias. It doesn't do it for everybody, or not everyone has watched Will and Grace, but it reduces the bias. What I'm saying is the media can be an effective tool, and there's actually even studies in Rwanda where this American researcher developed with local people a soap opera kind of radio program, but that was designed to reduce prejudice between the Tutsis and the Hutus, and it was effective in doing that. So yes, media, arts, and so on can be used. Again, it's building connections, it's making linkages, empathy, establishing emotional ties can be effective in reducing prejudice and bias. So there's evidence of that.
I think Dr. Winslow had a question down.
So he needs a microphone.
Who has the mic? Got to give it back. And then one more question after that, and we'll wrap it up.
Thank you.
Oh, thank you for.
You know what time it is on the East Coast? I'm just kidding.
It's been a long day.
It's fine.
I'll go fast.
Good to see you, Jerry.
Dan, thanks for the time. Your British example with the National Health Service makes me want to ask, are there, because I take it from your talk that really these disturbing relationships between racial prejudice and bad health outcomes is not just in this country, but around the world. But are there societies that do better? And if so, are there any factors that can be identified that have led to that?
It's a good question. I work with colleagues in Australia, New Zealand. I've done work on this topic in South Africa. Was in Brazil in the fall. It's a global problem. I think where the U.S. is ahead is that we document the problem better than other countries. We collect the data. Some countries don't collect data. In some countries it's illegal. France, it's illegal to collect data by race. You cannot ask, the government can't ask someone the question. The claim is linked to the French Constitution. But it's illegal to even ask someone their race. So that we have more data, we can document the problem better than other countries. I would say there are many countries where people would say there is no problem. I worked with the Toronto Public Health Department and in Ontario. Many Americans don't realize, but Ontario, Canada was the final stop for many on the Underground Railroad. So the average person in Ontario, long-standing people, they know America had a racial problem. We don't. We were the land of the free and the home of the brave. We welcomed the freed slaves. So what I'm saying, so the mythology that we don't have a problem is very common in some countries. I worked with the Pan American Health Organization years ago on an initiative looking at the health of the African descended population, the indigenous population in Latin America, and I met with leaders from those countries, activists, and what they said in most of their societies, the challenge they face is getting their government to admit there's a racial problem. Because the governments only want to admit there's a poverty problem. So I think we have more data. I think there are innovative things that have been done in the US. There have been innovative things that have been done in Australia. I have colleagues in Australia that have developed a museum exhibit, that have developed like signs and along buses and have, so they're innovative things that have been done, and some of them have been tested and worked, but I don't know honestly of a society that I would say as a society as a whole. And what's even more distressing, we are in a particular political environment where many people feel empowered to be more hostile and insensitive to others they don't value. There's a lot of scientific evidence on this, and those things also matter for health. So I think we are in a space when, as Christians, maybe I should end on this note, when as Christians we should take the lead. Historically we have not. There was a book published in the 1970s called The Bias and the Pious. And it was a review by Ditz. It was a review of the research on religion and prejudice. And what studies in the United States up to that point had documented was across these United States, the more religious you were, the more likely you were to be racially prejudiced.
Whoa.
The more you held conservative religious beliefs, like the virgin birth of Jesus and the Bible as the word of God, the more frequently you attended services, the more likely you were to be great.
Whoa.
Yes. Recent studies document that patterns still persist. The good news, there's good news. Researchers went back and analyzed the data. There are two types of religiosity. There's what's called intrinsic religiosity, the psychologists have identified, versus extrinsic religiosity. Intrinsic religiosity are people for whom religion is a driving force, integrated, that shapes everything they do in life. Extrinsic religiosity are people who use religion. It's a badge of social status, it's a badge of they're respectable and they're decent, and it's utilitarian for them. The tragedy is most religious people in America are extrinsic. And so that's why you find, because what the research finds, extrinsically religious people, the more religious you are, the more prejudiced you are. Intrinsically religious people, the more religious you are, the less prejudiced you are. But the overall effect reflects the fact that most people
Are extrinsic.
Most Christians are extrinsically religious. In terms of the current research, there's a body of work recently that is not using so much the intrinsic, extrinsic, but they look at the extent to which people are kind of dogmatic in their approach to life. And they find that people who feel they are right and everything is wrong, everyone else is wrong, their understanding of things is absolutely correct. And they are dismissive of any other view. They don't even need to hear anything. It's the rigidity with which people hold their own opinions. And I think I've talked to Adventist audiences and I say that should be a wake-up call for us, because there are some Adventists who believe that we have the truth and we have all the truth. And I believe we have a statement of doctrine that does not contain error. That's not the same as having all the truth. Only God has all the truth, and the path of the justice is a shining light that shines more and more unto the perfect day. So we should be in a constant state of learning. So, and the Lord preparing us with increased knowledge and wisdom and understanding. So I do think as religious people, just drawing on that work, we can lead, we should lead. I would say the history of religion is we haven't always led. But there is an opportunity for us, and I think that's what God wants for us, to be leaders. And we can talk about Jesus and his own example in his life. He clearly, I have a sermon about this, but this is another time. But if you look at all of the steps that have been documented in terms of reducing implicit bias, you can find all of them in the ministry of Jesus. You know, telling the story of the Good Samaritan. That was counter-stereotype imaging. Everybody thought of the Good Samaritan as negative. Here Jesus took a negative character and gave it a total positive spin. You know, and you can find it all in the dealing with the woman at the well. There's a lot in his life. And so there's a lot that we can learn to make a difference, to let the light shine and make this world a better place, at least for those people we encounter. Thank you so much.
That's a wonderful place to end. Thank you.